Hi everyone. Is diagnosing anemia baffling you? Anemia is one of the commonest health problems which medical professionals come across in day-to-day practice. Yet, anemia workup is exhaustive and streamlining lab tests for anemia becomes challenging. Testing anemia workup. As a doctor, are you confused which test to advise to your patients? Hours of reading, medical information about anemia appears vast and scattered, consuming hours to understand, and after all that reading, clinical application of this knowledge appears challenging. Is it possible to understand approach to anemia in minutes? Yes. My series Pathology in Minutes. In this series, I am bringing key concepts in pathology and medicine in simplified and concise manner so that as medical students, you will be able to understand and revise these topics rapidly. The first topic which I have chosen for this series is approach to anemia. So let's begin. When you are suspecting anemia in a patient, what is the first test which you advise? It is CBC, that is complete blood count, also called as hemogram. On hemogram, the first parameter which you will see will be hemoglobin. If the hemoglobin is low, it indicates that the patient can be having anemia. The next parameter which you should see is MCV, that is mean corpuscular volume. There are various scenarios about the values of mean corpuscular volume. If the mean corpuscular volume is low, that is less than 80 femtoliter, the next test which you should see is peripheral blood smear. On the peripheral blood smear, if the picture is microcytic hypochromic, CRDW, that is red cell distribution width. If the red cell distribution width is increased, the possibility is patient is having iron deficiency anemia. For that, you have to advise the next test, that is serum iron studies. In serum iron studies, the tests which are included include serum iron, ferritin and TIBC, that is total iron binding capacity. In iron deficiency anemia, serum iron will be decreased, ferritin will be decreased and TIBC will be increased. With these findings, the possibility is of iron deficiency anemia. Iron deficiency anemia can be because of dietary deficiency of iron, abnormal iron absorption like in tropical sprue or gastrectomy, chronic blood loss through gastrointestinal tract or in menorrhagia or due to parasites or hematuria. There can be increased physiological demand of iron like in childhood, pregnancy and lactation, which can also lead to iron deficiency. To rule out the loss of blood through the gastrointestinal tract, the next test which you should advise is routine stool examination and occult blood examination in the stools. Now what will happen if the MCV is low, peripheral blood smear picture is microcytic hypochromic, RDW is increased, but the serum iron studies are normal. The possibility is of anemia of chronic disease. Anemia of chronic disease can be because of chronic diseases like chronic renal disorders, in chronic infections like tuberculosis or thyroid disorders. In cases of chronic renal disorders, we will see the next parameters that is RBC count. The RBC count will be low in chronic renal disorders. For tuberculosis, the test which we have to advise next are CB-NAT or culture sensitivity or PCR studies. For thyroid disorders, we have to advise thyroid profile test. Now what will happen if the MCV is low and the peripheral blood smear is showing fragmented RBCs, also called as schistocytes? We will also see the RDW. It will be normal. And the next test which we have to advise is reticulocyte count. If the reticulocyte count is increased, there are fragmented RBCs on the peripheral smear and RDW is normal, the possibility is of thalassemia. To confirm thalassemia, the test which you have to advise is HPLC or hemoglobin electrophoresis. Now, what will happen if the MCV is low, that is less than 80 femtoliter, and the peripheral blood smear is showing dimorphic RBCs? That means some RBCs are microcytic and some RBCs are normocytic. Here, the possibility is of sideroblastic anemia. The causes of sideroblastic anemia include alcohol consumption, lead poisoning, congenital causes, low copper or B6 level, and myelodysplastic syndrome. In cases of excessive alcohol consumption, the peripheral blood smear will show target cells. In cases of lead poisoning, there will be basophilic stippling seen on the peripheral blood smear. In cases of myelodysplastic syndrome, we will see dysplastic RBCs and WBCs on the peripheral blood smears. Now, if the patient is having low HB but the MCV is normal, that is in the range of 80 to 100 femtoliters, again we will see peripheral blood smear. In this case, the peripheral blood smear will be normocytic and normochromic. Now, the next test which you have to advise here is again reticulocyte count. If the reticulocyte count is high, the possibility is of hemolytic anemia. The next test here which you have to advise is Coombs test. The Coombs test, if it is negative, it indicates the causes of hemolytic anemia like hemoglobinopathies. Example is sickle cell anemia, or severe bacterial infections, or enzymopathies like G6PD deficiency, microangiopathy like macroangiopathic hemolytic anemia, membranopathy like hereditary spherocytosis. If the Coombs test is positive, it indicates immune type hemolytic anemia, which can be autoimmune hemolytic anemia, alloimmune hemolytic anemia, or drug-induced hemolytic anemia. Now, if the MCV is normal, PBS is normocytic normochromic, and the reticulocyte count is low. Next feature which you have to see is whether there is pancytopenia. That means all the cell lines, that is RBCs, WBCs and platelets are decreased. In this case, there is possibility of aplastic anemia, bone marrow failure, myelofibrosis, leukemia or metastatic infiltration of the bone marrow. If the reticulocyte count is low but there is no pancytopenia, the possibility is of anemia of chronic disease or red cell aplasia. Now, if the patient is having low hemoglobin but the MCV is raised, that is more than 100 femtoliters, then it is macrocytic type of anemia. So, on the peripheral blood smear, we will see macrocytes and normochromic blood cells or RBCs. The causes include megaloblastic anemia. For confirmation of megaloblastic anemia, the common tests which are done are vitamin B12 and folate levels. We can also do Figlut test, which is not very common. The possibility of one of the causes for megaloblastic anemia is pernicious anemia. For diagnosis of pernicious anemia, we can do intrinsic factor antibody test or antiparietal cell antibody test. Schilling test was also used to be done in the past, but it is not very commonly done. Another common cause of macrocytic anemia is liver diseases. So for that, we will do liver function test to see if they are deranged. Now, macrocytic or megaloblastic type of anemia can also be seen in one of the neoplastic conditions, that is myelodysplastic syndrome. To differentiate megaloblastic anemia from myelodysplastic syndrome, we will advise serum LDH level. So see how concisely and within minutes most of the tests which are used for diagnosing and typing of anemia can be approached systematically and in a simplified manner. I hope you have understood all these tests and approach to anemia. If you please like, share and subscribe. If you want any video on any particular topic, please send the comment so that I can make video on that. Thank you.